Hi, this is Dr. Bryon Adinoff. Welcome to Doctors for Drug Policy Reform, webinar on a health-focused approach to drug use. This webinar was inspired by a call for a global day of action by the organization Support Don't Punish. Support Don't Punish is a global group that is designed to reduce the stigma of drug use and violent and neglectful policies and practices against our communities and ensure redress for all. The global day is actually June 26th. And so for those of you in Asia and Australia, it is June 26th. And over here in the Americas, it's a day earlier. As president of Doctors for Drug Policy Reform, or D4DPR, I was inspired by this global day of action to reach out to my physician colleagues around the globe and offer a health-centered perspective on drug use and problematic drug use. We're offering 2 webinars at different times and hopefully in 35 languages, assuming the Zoom translation works as intended, to assure accessibility to most everyone. A little background on our organization. D4DPR started out in 2016 as the brainchild of Dr. David Nathan, who's a psychiatrist in New Jersey and in the US. And he founded Doctors for Cannabis Regulation, or DSCR, after seeing the reluctance of his peers reluctance of his peers and other in medical organizations to endorse cannabis legalization and regulation. But when talking to his peers in private and confidentially, they acknowledged that legalizing cannabis is probably a good thing. So he started this organization to pull doctors and other healthcare professionals together to be a voice for legalization and regulation. I became president of DFCR a couple of years ago, and last year, the board felt it was the time was right to move the organization forward and address all drug prohibition. As it turned out, the global physician organization, International Doctors for Healthier Drug Policies, had to close their doors at this time, and we were privileged to take over their work on a worldwide scale. So on October 2nd, 2023, D4DPR announced our expanded mission to become a global voice for licensed health professionals and scientists advocating for evidence-based drug policies and best practices that advance public health, reduce stigma, and minimize harm. Some housekeeping issues. In addition to myself, we will have 3 superb speakers. Each speaker will talk for 15 minutes. The recording is in progress, and both webinars will be available on YouTube after editing, because we'll be having the same one in about 12 hours with slightly different speakers. Everyone who signed up for the webinar will receive a notice when the videos are available. Please keep yourself on mute throughout the webinar. After the speakers are finished, there will be approximately 20 minutes for Q&A. The Q&A will be moderated by Dr. Deandra Wright. Please enter questions in the chat during the talk and feel free to comment during the talks in the chat. I truly appreciate the contribution of our speakers, most of whom I did not know until I reached out and asked them to speak. And I just met Mark and Gideon. And I appreciate the efforts of our D4DPR Operations Manager, Lisa Capitani, as well as Deandra Wright and Hunter Platzman, in helping to make our webinar a success. And I will give myself an introduction. I am an addiction psychiatrist, neuroscientist, academician, and advocate. Prior to my retirement from full-time academia in 2018, I was Distinguished Professor of Alcohol and Drug Abuse Research at the University of Texas Southwestern Medical Center in Dallas, Texas, and I was a VA physician. I was a physician at the Department of Veterans Affairs for about 30 years. I'm presently the editor-in-chief of the American Journal of Drug and Alcohol Abuse, and I'm a clinical professor at the University of Colorado Anschutz Medical Center. in Denver. In academia, my career was focused on exploring the neurobiological mechanisms of problematic drug and alcohol use. And as you see, I will be speaking on a health-focused approach to drug use and problematic use and why so many healthcare professionals oppose it. So let's start out from a medical perspective, certainly the perspective that I grew up in. Addiction is a brain disease. It is, according to American Society of Addiction Medicine, addiction is a primary chronic disease of brain reward motivation, memory, and related circuitry. Without treatment, addiction is progressive and can result in disability or premature death. We see brain changes in people with addiction. And we know that at least 50% of the likelihood of somebody becoming addicted is genetic. So with that in mind, it's kind of strange that the war on drugs uniquely criminalizes the etiology of a medical disorder. So it criminalizes the etiology of addiction. And it's weird because we have lots of things that hurt us that we use voluntarily. And yet we don't make a crime out of it. Tobacco, alcohol, fatty foods, high carbohydrate foods, dangerous behaviors. They're all things that we accept the risk and we don't criminalize. So why are we as health professionals okay with this? First of all, I want to point out why we have this organization. It's because we believe that the opinion of health professionals matters. This is a survey taken in the United States, and over years, these results keep showing up. I suspect it is the same in other countries. We come from a wide variety of various cultures throughout the world, but I believe health professionals are generally seen as a trusted source. We may not like doctors overall, but we trust our doctor or pharmacist or nurse. And I think one of the reasons why physicians in particular are not aware of the problems with prohibition is that it doesn't really affect us. This slide shows in the US, and my talk is going to be US centric because that's what I know the best, and that's where I've lived all my life. And pay attention to the orange blocks. The orangest block on the left is the lowest medical students coming into their first year of medical school. They're in the lowest, their family is in the lowest quintile of income. Of the lowest 20% in income, 5% of incoming medical students are in that quintile. If you look over on the right, the highest 5%, those medical students coming from the highest 5%, not the highest quintile, but highest 5% is 25% of med students. If you're talking about the top quintile, the top 20%, 50% of med students come from that. So they come from that background and they stay in that higher income bracket. And so if they get arrested, if my kid gets arrested when he was younger, either one of them, for drug use, I would have been able to afford a lawyer. They would have gotten off. And the same for everybody in my community. If you're poor, that's not an option. And you land up without a lawyer in jail for possibly long periods of time. So I think, and the same for people in your community. So I think it doesn't touch physicians in the same way that it touches the people that bear the brunt. In this country, certainly Black and brown people of limited means. Another reason is, for reasons that I find somewhat puzzling, we don't understand, even though we have seen the success of non-prohibition interventions for, say, tobacco use in particular. In the US, the rates of adult use have gone from 51% to 19% over a period of about 50 years. That's an amazing improvement in decrease in use. And we see this even more dramatic change in 12th graders from 29% to 7% over the same time period. That is really tremendous. With just prevention, education, taxation, and regulation, we didn't need to throw people in jail. There is what's called availability bias or observer bias. We know what we see. We know what we experience. And if the ER doc is taking care of people that come in and withdrawal, drugged out, overdose, that's what they think of drug users are like. They don't see them in recovery. They don't see them when they're doing well. By definition, they're not seeing them when they're not sick. So they don't see them in that environment, in a good environment, and they don't realize, even though it's likely that one of their loved ones, it's very likely that one of their loved ones has an addictive disorder. And nowadays, certainly in the US, it would not be unusual for them to have somebody in their community or someone in their family who's overdosed. Nevertheless, there's still a sense that these are other. Medical health professionals are susceptible to the push for prohibition and stigma against drug users and cartels that we see. It's intense, it's persistent, it's widespread, and it's supported by powerful organizations, political organizations, industry, big pharma, the jails and prisons. There's many things that are pushing prohibition and stigma against drug users in our culture. And we are influenced by those same political winds, moralistic judgments, religious fever, economic forces, and media propaganda as everybody else. And it seems in some ways we may be more susceptible. There's uncertainty whether it will work. We see the consequences of drug use, but we don't know for sure that regulating it, decriminalizing it will be effective. And even when it is in places like Portugal and Czech Republic, even when even when we have examples, there's still some blocking that, well, maybe it won't work here. We saw in Oregon, state in the US, where they decriminalized it for 3 years and there were still problems. You know, of course, there's still problems. We've had prohibition for 100 years and it hasn't worked, but still we revert back to that and decriminalization was pulled. And this is very real, and I think this is somewhat specific for a healthcare professional, that there is a real risk. I had somebody tell me when I gave a talk before I retired, a couple years before I retired, and I was calling for regulation, legalization of cannabis. And I said that, and they said that what I was doing was courageous. And I said, you know, I've worked for the VA for over 30 years. I've got a pension waiting for me. At this point, go ahead and throw me out of the VA. It's time for me to go anyways. That wasn't courageous. If I did it when my kids were little, when I had a mortgage, when I had college facing me, when I had day-to-day expenses that I really had to meet and no other way to make them but through my job, that would have been more courageous. Hospitals are afraid. We're afraid of our practice, that patients won't come see us. The lawyers in the hospitals are saying this is dangerous. And so there is a real reality to physicians coming out and speaking up on this. And to this day, even in the states, with half of the states already having legal adult use cannabis, we still have doctors in non-legal states where there's medical cannabis afraid to speak up. but there's hope. One of the big things I think that really, really helped was that the diagnostic criteria for substance use disorder was changed when we went from DSM-4 to DSM-5. Um, for those of you who don't know DSM-4, or well, I guess most of you probably aren't psychiatrists. You may not know DSM-5. So one of the criteria for substance use disorder was substance-related legal problems. Recurrent substance-related legal problems, arrests, such as arrest for alcohol-related disorderly conduct. And what we found was that this is a network model where it shows how closely correlated the various criteria are. And what you can see here on the left is legal issues in DSM-4 is all out here by itself. It didn't correlate well with the other criteria that all clustered very nicely. Whereas we added in craving in DSM-5, and that did cluster nicely. And it was said that we were using, the legal criteria was using a socially constrained phenomena to define a disorder that may be problematic. Meaning that if you had a legal problem, it meant you were poor and Black or brown in this country anyways, in the United States. So it had to do with your culture, your background, your income bracket, way more than it did that you were using an illegal substance. There's Doctors for Drug Policy Reform. We're here. ASAM, American Society of Addiction Medicine, recently came out with this, you can read it, a call for decreasing criminal penalties for drug use. Where they say, where is it? Eliminate criminal and onerous civil penalties. Well, what's onerous for some people is not onerous for others, but still, it's a big start. The California Medical Association and the American Heart Association have come out for cannabis legalization. The AMA last week, the delegates of the AMA voted 345. Oh, the American Medical Association, I don't know if I said it, the name, came out 345 to 171 for the elimination of criminal penalties for drug possession for personal use. That is a really big deal. The delegates are younger than the board. The board is against it. The incoming president is against it. So as far as I know, the AMA hasn't endorsed this, but this is a big move that the delegates have voted for it. And we have a lot of things that are really based in harm reduction in the US anyways. We have, that's methadone and Suboxone at the bottom, that is in increasing use every year. We have needle exchange in most of the country. So there's a lot of things we're doing that are right. And then we have Nora Volkow, the director of National Institutes of Drug Abuse in the US, who came out just a few years ago. This was a surprise to me anyway. She said, we have known for decades that addiction is a medical disorder condition, a treatable brain disorder, not a character flaw or a form of social deviance. Yet despite the overwhelming evidence supporting that position, drug addiction continues to be criminalized. The USA must take a public health approach to drug addiction now in the interest of both population and well-being and health equity. So this was a very important statement from Nora. Again, unexpected, but I see a very important step forward. And I just want to finish with this quote that I love. She's from Melissa Moore in Drug Policy Alliance, and she's not a health professional. And it says, and I will stop here, how do we switch from a criminal approach to drugs to one that is much more rooted in providing people with care and the resources that they need if they are experiencing problematic use, and leaving them alone in dignity and peace if they are not experiencing problematic use. So thank you very much, and we will move on to Dr. Lasco, who joins us from the Philippines. Okay, Dr. Lasco is a physician, medical anthropologist, and drug policy scholar whose research includes ethnographies of drug use in the Philippines, as well as the politics and drug wars in Asia. His particular research interests include the histories of medicine in the Philippines and Southeast Asia, specifically in charting social and political responses to medical issues like HIV, AIDS, SARS, COVID, illegal drugs, and vaccination scandals. He has written the Asia chapter of the past two global state of harm reduction reports and is board member of the International Society for the Study of Drug Policy. He's currently pursuing a master's degree in the history of science at Harvard in pursuit of broadening his knowledge in the social sciences of medicine. And Dr. Lasco was speaking on the medicalizing drug use, context, and consequences.
Thank you so much, Bryon, for this introduction and for inviting me in this very important conversation about how we can respond to drug policy, not just as individuals, but as doctors, as health professionals. There's a particular resonance. As I will argue in my presentation, doctors have a uniquely positioned role and responsibility, either to push for drug policy reform or to help reinforce the status quo, which is prohibition around the world. So let me again reaffirm that, and building on what Bryon said, that the medical profession has the power to reinforce misguided drug policies or pave the way for badly needed reform, which is why those statements matter from the AMA and other organizations. So I approach this from an anthropological perspective and also from a history perspective, and really asserting and reminding ourselves how drugs have been part of humanity's experience since ancient times. So people have always been intimate with different psychoactive substances, and whether we classify some of them as drugs or as medicines or as supplements or whatever kind of substances you might want to label is something that's evolved over the centuries, and it's not a given for a certain drug to be labeled as such. In fact, if we look at psychoactive substances from cannabis to alcohol and to many different substances as well, kava in Oceania, betel nut chewing in this part of the world in Southeast Asia, and so many other substances, we see how it's not all the time that people use it for a certain stereotypical use for partying or for intoxication, but it's actually figured in different parts of the world for different purposes: economic, recreational, medical, and so on. It's not really useful to have all of these distinctions because they're all heterogeneous. So in a recent trip to Mexico, I found that, in fact, tequila and mezcal, these Mexican liquors, the technology to make them actually traveled across the Pacific from the Philippines, where people have been making this beverage called tuba, a distillation technique that's to distill coconut liquor, and it's been applied to Mexico. So these ideas travel across the oceans, across the centuries, and again, people use them for different purposes. So this one, if you see this slide, this one is a billboard for a gin brand in the Philippines, and it's calling on people to avoid drugs, and yet it's advertising alcohol, it's advertising liquor, even though we know that in terms of the levels of harm, alcohol is actually much more problematic than many of the drugs that are illegal. So as Derrida famously said, the concept of drug is actually not positive. It's not a fixed concept, but is a basis of moral and political evaluations all the time. So it's good to be reminded of this. It's good to be reminded that some of the most problematized drugs today used to be pharmaceuticals, used to be advertised in medical journals as wonder drugs, including cocaine, which has a very particular history in US medical practice. It used to be a wonder drug, and as you can see in these old advertisements, it was being hailed as an anesthetic, as an ophthalmic solution, and so on. Now, we see also that the criminalization of drugs from the 19th century onwards has had devastating consequences. But not only that, but the medical profession was somehow involved in the discourses around the harms of drugs that led to this prohibitionist regime. So to complicate the distinction between a criminalized approach and a medicalized approach, we see how the medicalization of drugs actually has fed into the punitive regime that we see around the world, and also the criminalization of drugs. It was the medical rationale of harms for these drugs that help inform political actions towards prohibition and criminalization. But of course, nowadays, we see a shift in the discourse. We see more and more medical professionals speaking out against the global drug control regime, many doctors speaking out against misguided policies. And yet, the medicalization of drugs today remain heterogeneous in itself, in the sense that it's not just because people are saying drugs is a public health issue doesn't mean that it's evidence-based. It doesn't mean that it's actually working for the people that these policies are supposed to help. In my home country of the Philippines, for example, the Department of Health always talks about how drug is a public health issue, even in the middle of this genocidal drug war that just took place, that killed tens of thousands of people who use drugs. When they say public health, sometimes they end up meaning rehabilitation, which is essentially compulsory detention in the case of the Philippines. So just because someone is saying drugs is public health or we should do a public health response doesn't mean that we're all on the same page. And we need to be critical as well of how people use health as a trope in itself. We also see how, for many, the anchoring of drugs in public health is hinged on HIV/AIDS. So this includes harm reduction, and harm reduction organizations are now trying to depart from this, even though this has been very useful for the past few decades to be able to receive attention and funding and support. Harm reduction programs needed to be latched on to HIV as a rationale. So injecting drug use became the focus of many harm reduction responses, even though it's harm reduction is more than just these programs, needle syringe programs, opioid agonist programs. So we need to also depart from that and to recognize how HIV has become a vehicle for talking about drugs in the context of public health in a politically acceptable way. So in the paper that we wrote interrogating drug rehabilitation in the Philippines, we saw how people are saying that this is very good because we're not killing people. And yet when we look deeper into what this rehabilitation really means, we see that this are privately run programs that are very inhumane in conditions, human rights violations. The characterizations of these centers are very problematic in itself, and yet they get passed on as a good thing as compared to jailing people and killing people. Sometimes the medicalization of drugs can also lead to policies like testing. So if you look at drugs as an epidemiological variable, then why don't we survey everyone? Why don't we test? So in the Philippines, it became a policy for a while to actually require the testing of kids for drugs. And as you can imagine, this led to a lot of problems and students dropping out for fear of being targeted in the drug war. So we also see across the region, and I'm speaking from the Southeast Asia perspective, but I'm also relating it to the American context in which some of these things have parallels. So even if the laws say that the public health agency should take the lead in drug policy responses, it's not happening in practice. So in Indonesia as well, the laws are very high sounding, and we need to divert people from prison and towards treatment. And yet there's discrepancies towards rhetoric and practice. Vietnam is more progressive in the sense that it actually supports harm reduction programs, and yet there's also inconsistencies in Vietnamese drug policies, especially for amphetamines. So sometimes the way different drugs are responded to, it's not just one drug policy, but there's different policies for different kinds of drugs, which also reflect how different communities, different people, different groups are associated with particular drugs, which in itself has a problematic history. But we see that in Vietnam as well, that amphetamines are treated differently. There's political resistance to harm reduction. So politicians as well can invoke medicine. So we need to be careful about how our language can be appropriated by political actors. We see in Indonesia, for example, how the former president, has spoken of the threat to public health as a rationale for punitive responses. So Jokowi saying that it's a threat to public health. And Duterte in the Philippines, who really masterminded this drug war, insisting that methamphetamine causes brain damage, permanent brain damage, which is why it needs to be especially problematized. It needs to be dealt with in murderous ways because it destroys the brain. So this is a medicalized language that needs to be called out. And again, the medical profession has a role in that. So there's also a need to really move beyond just heterogeneous view of drug use. There are many categories of drug use, and that's also not being reflected in some of the discourses. So there have been, thankfully, a lot of discourse around how problem drug use is just one small subset of drug use itself, and how around the world results show that majority of drug use is actually episodic and non-problematic. But again, this is not reflected in discourse. One of our health officials in the Philippines, I remember telling me that, yeah, I know that drugs destroy the brain because when I'm in the ER and I'm an ER doctor, I see them all in violent state. So this person who's in the ER is using his experiences as an ER doctor to generalize all people as necessarily needful of emergency treatment. So we must be also reflective on our positionalities and what our experiences shape in terms of our perspective. So of course, an emergency room will see the worst kinds of drug use, but that's not reflective of the whole spectrum of drug use. So we see a lot of barriers still, criminalization. People won't seek care unless they're guaranteed that they won't be penalized for doing so. People should feel safe to disclose that they use drugs without fear of arrest or detention and even stigma and discrimination. In the Philippines, we see how it's actually the departments of medicine that's taking the lead in calling for prohibition. So again, it reminds us how doctors play a privileged role in either perpetuating drug policy or reforming it. This is the university where I come from, calling for saying no to legalization and calling for prohibition. So my concluding thoughts basically that public health response is impossible without ending the prohibitionist regime. But at the same time, again, ending it is impossible without public health moving away from medicalizing drug use in a different direction. So we can medicalize it in a way that helps people, but it can also be the other way around. Harm reduction is the most amenable to medicine as a necessary but not sufficient component of drug policy. We need to be wary about the conflation of use, abuse, dependence, addiction in ways that reinforce the current paradigm, and that people who use drugs are all the same, and all drugs are also the same. So again, this homogenizing discourse needs to be challenged. We need to look at the overall context, also being aware of how politicians can mobilize medicine towards their own ends to appeal to populist views, people's moral panics around drugs. And finally, I can't say this enough that we, as a medical profession, we have the power to either reinforce misguided drug policies or pave the way for badly needed reform. So more power to those of you who are challenging drug policy, and I express solidarity from my part of the world, and I hope we can continue this conversation. Thank you so much.
Thank you very much, Dr. Lasco. That was excellent, and I like it. It was a great follow-up to my talk. You brought up a lot of things that I wish I had. Our next speaker is Dr. Alex Wodak, who is joining us from Australia. Dr. Wodak spent 30 years. Wodak spent 30 years establishing and running an alcohol and drug treatment service in a teaching hospital in Sydney, Australia, where he became increasingly involved in harm reduction and drug law reform at the national and international level, because of concern about the uncontrolled spread of HIV. He helped establish the first needle exchange syringe program and the first supervised injection center in Australia when both were pre-legal, and often works in developing countries on HIV control among people who inject drugs. For the last 8 to 9 years, Dr. Wodak has advocated for tobacco harm reduction, as he believes the 8 million global smoking-related deaths per year could be rapidly reduced if tobacco control, public health, governments, and the WHO accepted the abundant and growing evidence that safer nicotine options are much less dangerous than smoking. And he will be speaking on this topic, why the ferocious opposition to tobacco harm reduction is the biggest issue in drug harm reduction in the world today. Thank you very much, Dr. Lowell.
Thank you, Bryon, and thank you to Doctors for Drug Policy Reform and to your colleague Lisa for helping out. I'm very pleased to be discussing this with you today. I hope we can have a conversation. What I really want to talk about, or start off talking about, is why Doctors for Drug Policy Reform is exactly the right group that should be interested in this subject. So, first reason is because compared to deaths and diseases and other harms from all other psychoactive drugs, alcohol, prescription drugs, illicit drugs, the deaths and diseases and other harms from tobacco dwarf the combined deaths and diseases from all other psychoactive drugs. Not just all other psychoactive drugs, at least in my country, in Australia, you can add into that total deaths from HIV plus suicide plus road crashes, and deaths from tobacco still outnumber them. We have 8 million deaths a year from smoking and worldwide, and we have my country 21,000 deaths from smoking. In the US, I think it's 450,000 deaths a year. We have for each person who dies from a smoking-related condition, loses somewhere between 12 and 13 years of lost life expectancy. Smoking is also a major contributor to health inequalities. Amongst the most disadvantaged quintile, 20% of our population, smoking accounts for half of the gap in life expectancy between the top quintile and the lowest quintile. And there are many other factors we could go into. So it's a really big issue. It's also an issue that should be very relevant, I believe, to us for other reasons. Let me run through some of those. One of the reasons is that the harm from smoking is spread very unequally in our communities. The people who smoke most, who are more likely to smoke and who smoke most cigarettes a day, are the poorest 20% in our community. And they're also in that group of people who suffer most from tobacco-related health problems, Indigenous people, people with severe mental illness, people with severe alcohol and drug problems. And indeed, it used to be thought that what we should do when we're providing treatment for people with problematic drug use is that we should treat the problematic drug use first and then treat the smoking problem second. What's been found in recent years is that we get better results from drug treatment if we treat both conditions simultaneously. So that's another reason. And the people that most of us in Doctors for Drug Policy Reform would care about, people with severe alcohol and drug problems. Of course, heavy smokers lots of tobacco-related illness, and as I just said, do better if we treat their smoking problem at the same time as we try and help them with their other drug problems. But I think yet another reason why we should be providing more support for international efforts to support drug law, tobacco harm reduction, is because the relentless resistance and opposition to tobacco harm reduction damages our advocacy for drug harm reduction. There's a real pattern whenever a new kind of intervention for drug harm reduction is introduced anywhere around the world, and that is that no matter how strong the case is for introducing that new drug harm reduction intervention, there is always ferocious resistance. That happened with needle syringe programs, it happened with methadone treatment, not so much with buprenorphine treatment, but it happened with injecting rooms, it happened with pill testing, and I'm sure this is true in your country as much as it is in my country. And it certainly has happened with tobacco harm reduction as well. The two are inextricably linked. And I don't understand why it's possible to support car seat belts and motorcycle helmets and condom promotion and PEP and PrEP for HIV and needle syringe programs and methadone and buprenorphine and treatment and hydromorphone and diacetyl morphine treatment to support all of those things and the many other things we do in drug harm reduction, and yet be opposed to tobacco harm reduction. They're inextricably linked in my view. Now, all of this is predicated on the assumptions we make about the relative risk of tobacco harm reduction compared to smoking. And there are many official bodies that have looked at this, and NASEM in the United States, the National Academy of Medicine, Science, Engineering, I might have got that title slightly wrong, is one of the many bodies that's looked at this, and their view is that the risk of tobacco harm reduction, in this case vaping, is substantially lower than that of smoking. And it's hard to see how they could take another view. As I said, 8 million deaths a year from smokers, where per year worldwide there are 1.2 billion smokers worldwide, and we have 82 million people estimated to be vaping around the world in 2021. That'll be more now. And so far, there hasn't been a scientifically attributed death from vaping nicotine anywhere in the world. And vaping exists in scores of countries. And as I said, 82 million people in 2021. So vaping and other forms of tobacco harm reduction have captured about 10% of the total nicotine market in 15 or 20 years. It's really quite remarkable, and that's speeding up. But what is the other evidence that vaping is likely to be much less dangerous than smoking? Cigarette smoke has about 7,000 chemicals, including 70 carcinogens, and of course also lots of carbon monoxide. Aerosol from vaping has 100 to 150 chemicals at about 1% of the concentration that they are present in cigarette smoke, and of course very little, if any, carbon monoxide. A lot of the science around this is fiercely contested, and the opponents, in my view, the opponents of tobacco harm reduction have been, like the opponents of drug harm reduction, have been quite dishonest very often. Now, there are 4 recognized forms of tobacco harm reduction apart from vaping. We also have snus, which has been around in Sweden, popular amongst the men rather than the women, for about 200 years. So we know a fair bit about snus over a long period of time, and it provides proof of the concept of tobacco harm reduction. I'll come to say more about Sweden in a moment. And then we have heated tobacco products, and these have existed on the market since about 2012. And the most common brand of that is the IQOS, produced by Philip Morris International, who spent $12 billion bringing that product to market. And it's clearly the market leader in that category. And Philip Morris International is the largest traded tobacco company in the world by a considerable margin, but it's not the largest traded, it's not the largest tobacco company overall in the world. That honor belongs to the China National Tobacco Corporation, which makes about 40% of the world's cigarettes, and so far has no interest in tobacco harm reduction. And then the third form of tobacco harm reduction is are the nicotine pouches. So that's where we are at the moment. Now, just a word of going back to Philip Morris International. They decided in 2004 in their research committee to stop spending money on trying to so-called improve the cigarette. So they stopped research in that. And they decided also to start spending money on reduced risk products. And out of that came IQOS and other things as well, but IQOS is by far the main, the most important product they make in this category. In 2015, reduced risk products accounted for less than 1% of PMI's revenue, and now it accounts for reduced risk products account for over 40% of the revenue of Philip Morris International. They're aiming to reach 50% next year and 66% by 2030. Of course, we don't know whether they'll reach those targets, but that's what they're aiming for. And they're actually aiming to reduce the volume of cigarettes they're producing, which is pretty significant. But there's been a ferocious campaign to resist tobacco harm reduction products, as there was a campaign against every other new drug harm reduction intervention. So that's where we are in the moment, and there's a ferocious fight with Mike Bloomberg and Bill Gates generously funding opposition to tobacco harm reduction. The World Health Organization, always broke, is once again opposing harm reduction, as it did 25 years ago oppose harm reduction for injecting drug users. Hard to believe, but it did for several years, acting under the baleful influence then of the United States. That lasted for a few years, and then they reversed that in 2000 just as well. So we're seeing some important developments in the last few years in tobacco harm reduction, and one of them is New Zealand. Now, so two countries that we should take particular notice of is New Zealand and Sweden. Now, New Zealand began regulating vaping in 2020 with the specific aim of making vaping more available than cigarettes. Since then, in just 4 years, their smoking rate has almost halved. It's declined by 45%. In contrast, Australia is hostile to tobacco harm reduction, specifically vaping, and the smoking rate in Australia in that time has declined by only half as much as New Zealand. Australia has a huge black market, which has now become criminalised, like other illicit drug markets, and New Zealand has zero vaping black market. So New Zealand's very important, and Sweden is also important because they've got their smoking rate down to 5.6. Women have taken up snus like men had much earlier, and Sweden is going to be probably the first country to have effectively eliminated smoking, getting under 5% probably in the second half of this year. So there's tremendous evidence, and the evidence is growing and is very impressive. So my recommendation to Doctors for Drug Policy Reform is we should include this in the things that we are interested in for all of those reasons. Thank you.
Thank you very much, Dr. Wodak. Okay, our last speaker in this webinar is Dr. Mark Tyndall, who joins us from Canada. Dr. Tyndall is an infectious disease and public health physician who has worked as a clinician and researcher in HIV prevention and harm reduction for over 35 years. He is a professor at the University of British Columbia School of Population and Public Health. He was co-lead investigator on the evaluation of Insight, North America's first supervised injection site, and his TED Talk on harm reduction has generated over 1.25 million views, and we'll put that in the chat. He's taken a leading role in responding to the overdose crisis in Canada with a focus on harm reduction interventions, providing a safer supply of drugs and the decriminalization of all drug use. He's recently stepped back from his academic activities to heal, reflect, and write. So I particularly appreciate Dr. Tyndall's taking time away from these activities to speak with us. Thank you for joining us.
Great, Bryon. Thank you very much. It's a pleasure to be here. As Bryon said, I've been sort of missing in action for the last couple of years. I've moved with my family to Bali, and following up on my friend and mentor Alex's comments, I've been working on a book about vaping and vaping harm reduction. And I might have done too much meditation, yoga, and scuba diving to finish my book, but that's on my agenda now. I've moved back to Canada. So I haven't really participated in this kind of thing before. When I left Canada 2 years ago, I was heading up what was probably a quite innovative program of harm reduction, where I had biometric machines that could provide people with hydromorphone pills as part of our response to a horrible epidemic of fentanyl drug poisoning that was occurring in Vancouver. So I'll just back up a little bit. I had many reasons to move to Bali, but at the end of the day, I think I really felt a bit burnt out, and and organizations like this are really, really important to know that the physicians who think that drug policy is important feel supportive and have a community to talk to, because I think most of us who've spoken today and many of my colleagues just do not feel very supportive and supported, and sometimes feel like you're banging your head against the wall, and you take one step forward and two steps backwards. And I feel I'm constantly trying to defend harm reduction, constantly pushing back on prohibition and the war on drugs. And some days it just feels like we're just not making that much progress. And as Bryon showed in his last couple of slides, that there is, and Gideon also, that there is hope and possibilities there, but it's really been an uphill grind. And people like Alex, who I've admired and followed for many decades now, could attest to the struggles it's been to try to make progress in these areas. And the physicians, my fellow physicians, many of whom see firsthand the devastation of drug use, just have not really decided this was an issue they wanted to fight for. And it's people go very quiet when there's opposition to harm reduction, when stigmatization occurs, when people are treated quite badly by the medical system. There doesn't seem to be a strong voice or a strong pushback to that. And again, doctors for drug policy reform are, really could be an important voice, obviously, but be a really important support for those of us who are working in this area. Just a little bit more background. My introduction into harm reduction really was on the basis of HIV. I'm a product of the HIV epidemic. I started medical school in 1982, and one of the first journal articles I ever read was about pneumocystis disease in the New England Journal among gay men in San Francisco, New York. And I've been really involved in HIV prevention since that time. I had clinics that I was involved with hemophiliacs and gay men in the 80s, when there was no treatment, and lots of horrendous opportunistic infections and death that I saw. And then I spent 5 years in the 90s in Kenya, where the terrible epidemic, a heterosexual epidemic in sub-Saharan Africa, and again, working in clinics and in research projects where there was absolutely no treatment, and just people dying. Our only harm reduction strategy at that time was condoms. And it's hard to believe that looking back, but there was huge opposition to condom promotion in the 1980s, in 1990s in Africa, and even huge opposition to education. So trying to get the word out to young Kenyans that there was a deadly sexually transmitted virus circulating. There was huge political and religious opposition to even talking to people about that. So those were really, really crazy days. And the most basic harm reduction now, such as a condom, which just seems so common sense, we really faced a lot of opposition to that in the 1990s. And then 1999, I moved to Vancouver and was introduced to the HIV epidemic among people who injected drugs. And Vancouver already was sort of, at least in North America, sort of infamous for high HIV rates and high public drug using. And although it was and remains confined to quite a small area of Vancouver, it's still the downtown east side has been written about and filmed, and there's been a million research papers around what's happening in that community. And in the 25 years I've worked there, it's really tragic to think that things aren't that much better, despite so many pilot projects and so many good ideas and so many committed people working there. The situation for people is still quite horrendous as far as living conditions. And although Vancouver would be thought of as a place where we can at least try different things, the overarching approach to drugs is still prohibition and criminalization, and it's really been tied in with poverty. And some people would say that poverty's been criminalized, so that people who living very unstable housing situations, often use some drugs, have really been vilified and stigmatized and poorly treated, and that continues now. We have, there has been little bright spots and things that even in the United States that are kind of still at the very infancy are quite well established now, at least in this community in Vancouver. So, starting in the 1990s with a lot of methadone availability, and it was really enmeshed in primary care. So they got away from, methadone only clinics and things, and methadone was treated as part of primary care. So that's always been very available since my time there. Needle and syringe programs, which in their infancy in the 90s, when it was a 1-for-1 exchange, that changed quite quickly, and boxes of needles are available at most health clinics now if people want them. And then, of course, supervised injection sites, and I was involved in Insight, and that opened in 2003, which is over 20 years ago now. There's been estimated 4 million injections happen in Insight, and not one death. So there's been plenty of overdoses, and especially the last 6 or 8 years, basically the place is an overdose center where naloxone and oxygen and people, slapping people to wake them up is just common, and so many people's lives have been saved because they've been their overdoses have been witnessed at places like Insight. Starting in 2016, the government allowed the opening of many more community-based supervised sites. So there's about 30 or 35 active supervised sites around the province of British Columbia. And some of the other provinces in Canada have opened 1 or 2, but not very many. And so although we have such strong evidence that giving people a safer place to inject, having connection with those people, developing some kind of community connection, help them get on with treatment is just so important and so effective. The pushback for supervised sites around North America is still quite harsh, and there's really little on the horizon in American cities that they'll be opening many sites anytime soon, and even other provinces in Canada. In 2016, I was the head of the BC Centre for Disease Control, which is the provincial public health center. And the statistics started rolling in that overdose deaths, which for decades, ever since I got there, was between 200 and 300 people would have a heroin overdose per year, which was still very high, but didn't really capture people's attention. All of a sudden in 2015, that tripled, and in 2016, that went up 5-fold. So in 1 year, there was over 1,600 deaths. And this toxicology from the coroner's office showed fentanyl pretty much in every one of those cases. And very quickly, the heroin flow into Vancouver, which was for always in my time there had been very high quality white powdered Afghanistan heroin that got into the streets of Vancouver, was replaced by fentanyl. And there's probably many reasons for that, but one is purely economics, and one is clearly is prohibition. It's much easier to put synthetic fentanyl on the street and other synthetic opioids than to bother transporting barrels or bushels of heroin around the world. So fentanyl remains the drug of people in Vancouver, and the ratio of getting high to dying of an overdose is just razor thin. And so people just get a little too much and they never wake up. And if you had told me in 2015 that there'd still be 2,000 people in the province dying every year of fentanyl, I would not have believed you. I thought the most most vulnerable people would have died in the first year or two, and then the epidemiologic curves would just by natural selection just start to go down. But really, it's been 8 years of solid 2,000 people dying of fentanyl, and it just doesn't seem to be ending. So that brought us to the next obvious thing, is to give people a drug that won't kill them. So there in about 2015, following the Naomi heroin trial in Canada, and it had some international sites, the people that were in the trial who did well on heroin were allowed to continue. So in Vancouver, there's about 100 to now maybe 130 people who can go every day or up to 3 times a day and get a heroin injection for free. And that's continued. So that's the obvious safe supply model. But clearly, with thousands of people being exposed to fentanyl, there is just no way that could expand. And for many people, visiting a health facility 3 times a day is just impractical and will not happen. So we needed to open up the safe supply route further. And we had some preliminary programs giving people hydromorphone pills, or dilaudid, as we call them here. And these 8-milligram pills could be ground up and injected, or over time, more and more people were either sniffing them or swallowing them. And to make the barriers as low as possible, I worked with a company who made these biometric machines, and you just put your hand up, it identifies the person who's there, and we allowed them to get dilaudid pills every day, once per day. And we had at one point 5 machines operating in the province, servicing about 150 people. We're still looking through some of the data, but it was highly successful. So a few people who did drop off the program have died over 5 years, but the vast majority of people are still alive, at least. And the success, many people have reduced their drug use. Certainly, almost everybody in the program reduced their street drug use, so reduced their exposure to fentanyl. And probably 20% of people stopped using street drugs altogether. It means that 80% of people, despite having a safe supply of pills, still occasionally used street drugs or fentanyl. But as a harm reduction approach, it was highly successful. Unfortunately, the government didn't refund the program. I've been out of the country, and as of March, the machines were put into storage. So I have to decide personally how much I want to try and revive this program. But it was a great experiment, and this is a harm reduction approach where you actually give people the drugs that they need to prevent them from buying drugs on the street that are killing them. I think is, to me, a commonsensical approach. And again, it just led to a lot of connections. So people, obviously, there was quite an in-depth intake for people. We had staff who followed up with people to see how they're doing. And it was really a great way to connect with people who otherwise were using alone. The irony of fentanyl and all these overdoses is all of a sudden we were telling people, well, just don't inject alone. And we armed the whole community with naloxone kits. And there's people in the community who are drug users who have saved 100 of their friends. Like there's a whole army of naloxone users. And if you walk down the street, some days there could be 3 or 4 simultaneous overdoses happening at the same time. And most of those people, their first contact is somebody from the community who's carrying a naloxone kit. So it's used highly effectively. But most people still inject by themselves because it's an illegal thing to do. So although walking down the streets of Vancouver, you see people that are openly using drugs, they're the tip of the iceberg, and most people are locked up in their hotel rooms, getting their drugs delivered and injecting by themselves, and often found dead. So
Thank you, Mark.
Okay.
I want to make sure we have time for
Yeah, okay. Sorry.
question. Listening to you and Alex, I realize that I'm kind of new to the field, and really what an honor to be on a webinar with people of your stature that have been doing this their whole careers and really are leaders. You've done so much, and I know you sound frustrated, but the supervised injection sites have continued over a period of more than 20 years, and we've been really trying to get them going in Denver, and are close, but not quite. But we look to, Vancouver for inspiration. Okay, Deanna Wright Tajiha, I'm not sure I'm saying that right, or Tahita, will be moderating our Q&A. Deandra is a rising second-year medical student at George Washington University in Washington, D.C., with a concentration in health policy. She also holds a master's in bioethics from Harvard Medical School and a deep passion for social justice that drives her goals for her medical career.
Thank you so much, Bryon, and thank you to our panelists for such great talks. As Bryon said, I'm a rising second year at GW Medical School, so I myself am very interested in these topics, and I have been really taking in all that everyone has had to say. So my job tonight is to help moderate the Q&A discussion. And so I want to encourage everyone again, all of our audience members, to place their questions in the chat. But just to start and to get us going, I was wondering about, in any of your opinions, the reason behind the negative connotation or the switch surrounding drugs in our societies and moving towards that more criminal view. And how does this criminalist view affect marginalist groups in each of your respective communities?
Well, I can say in the States, I would say that actually drug prohibition has been very successful in the United States. Drug prohibition was never meant to stop drug use. It was meant to incarcerate and disenfranchise Black and brown people. And in that respect, it has done what it aimed to do. We don't have the police going around and checking out corners in white upscale neighborhoods or crashing down doors. They only do it in Black and brown neighborhoods and then say that, well, that's where the drugs are, when in fact that's not the case. So I think that is part and parcel what the aim of prohibition was. And I'd be interested to hear about other countries.
Yeah, like, I mean, in Canada, what's obvious to outsiders is the disproportionate number of First Nations and Aboriginal people that are affected by this. It's just devastating. I've been involved in so many research projects, and we do keep track of ethnicity, and always there's 30% of people in our cohorts are First Nations, and they represent about 5% of the people in the province of British Columbia. So a huge disproportionate number of people who are impacted by addiction, and really goes back to trauma and just the violence, systemic violence that community has faced over the centuries, basically. So for us, that's a huge inequity point, and Bryon puts it as a success that we were really trying to make First Nations people submissive and invisible. Prohibition has really done that.
Yeah. Well, Alex, please go ahead.
Please, no, you go ahead. please.
Okay. Yes. So in the Philippines as well, there's parallels in Southeast Asia of what we've heard from Canada and the US. Inequity. This criminalization of drugs is perpetuated inequity. It's targeted low-income communities, mostly urban poor communities. It's targeted migrants as well. Singapore, the death penalty has been disproportionately applied to drug offenses, mostly targeting migrants who work in Singapore. So the criminal regime has affected these individuals that belong, they're already marginalized, but drug policies further exclude them. Drug testing, can you imagine having to apply for all kinds of jobs, but then you need to have this drug test? And if you test positive, it might lead to penal consequences. So it further excludes people. And that's just the tip of the iceberg. Again, the exclusion to health services, the exclusion to social services. Students don't want to go to school because of drug testing and they feel that they'll be targeted. And it all adds up to perpetuate existing societal inequalities. So again, I think that the medical profession has a big role in challenging this and pointing this out.
Well, unfortunately, the cancer of racism is ubiquitous, and Australia has a solid dose of it as well. It's not generally known that with the very early beginnings of global drug prohibition in the mid-19th century, Australia, the US, and Canada had a gold rush around about the same time, and that sucked in Chinese, people from China who were prepared to work on the gold fields in 3 states in Australia, California in the US, and British Columbia. And in each of those 5 states or provinces rapidly passed laws criminalizing the smoking of opium. The only people who smoked opium were Chinese. Nobody else smoked opium. They took opium, all right, but they didn't take it by smoking. So that was clear evidence of racism. And then as time passed, now speaking just about Australia, there was a widely read magazine called The Bulletin in Australia, and the subheading, the strapline on the title page said the magazine until 1961, I kid you not, said the magazine for the white man. And in the early 20th century, that magazine exploited racism, and particularly in beautifully drawn cartoons, black and white cartoons. And the cartoons had a consistent theme of fat Chinese men seducing young white women using opium. Australia has certainly been infected with this cancer to a large degree, and it's very common around the world. You can't really delve much into this subject in any country, I believe, without seeing that. On a positive note, the introduction of, or the regulation of vaping in New Zealand in 2020 has brought a dramatic reduction in smoking rates in the indigenous people of New Zealand who are called Maori, and their smoking rate has just plummeted. And they had amongst the highest smoking rates ever recorded in the world. So that's really a positive. And a researcher in New Zealand, Dr. Marawa Glover, has been stimulated, who's Maori herself, has been stimulated to look at reducing smoking rates by all methods, including tobacco harm reduction in Indigenous people throughout the world. So that's some positive news.
Thank you all for your answers. So what I'm hearing is across the globe, it appears that the criminalization and the connotation of drugs is affecting marginalized groups by continuing to perpetuate racism and marginalization. And it is our duty through drug policy reform to help to challenge that. And I think that's a good segue into this next question, that there's been a lot of discussion of the least stigmatizing language to use for people using drugs problematically, whether that's misuse, abuse, problematic, addicted, or just use or something else. What, in your opinion, would be a good label, or maybe not using a label at all, in order to help us towards this goal of destigmatizing drug use?
I think this is a very interesting question, because still these terms are used quite loosely, and I think are now thought as highly stigmatizing. So I think we try to use people who use drugs is a kind of benign thing, but even that can be a bit stigmatizing. So I mean, it's the language is really important. I mean, and making Bryan's comments, at the beginning about, making sure people understand this is a disease, even that can be a bit stigmatizing. So, if I ask somebody using drugs, do you think you have a disease? They would say no. They are using drugs for very many reasons, but it's not because they think they have a disease. And I think we can overplay that too, and that can be very stigmatizing. So I think it's tricky. There's probably no good way to describe it. And when I'm writing in scientific papers or articles or however, I always struggle with how to put it. Obviously, we don't use terms like an addict or, crackheads or, things that are obviously very derogatory. But I'm even uncomfortable sometimes when I'm referring to people who use drugs. But I think that, to me, that's the most benign thing. But it's tricky. And it's more, I struggle with it, but the best way is to ask people who use drugs how they want to be thought about. And most would say, well, why is it even necessary? Like, why are you calling me anything? So anyway, that's my thoughts.
Well, when I was you have to call it something when you are writing a title for a
Right.
webinar. So, for instance, I use health focused, I don't know, look at drug users, people who use drugs and misuse drugs, and the IDPC, the International Drug Policy Consortium. They said misuse is not a word they like, and they suggested just drug users. Others say problematic drug use. I know we've certainly gone away from abuse, but I've heard with people who use drugs, as a journal editor, people will then use an acronym, PWUD, which all of a sudden you've put a label on it, an acronym. So as you say, that can be problematic. So like with DSM, you have, when you're diagnosing somebody as a physician, you have to put something. So what do you put? You have to refer to them in some way, I think, right?
Look, I think we have to accept that there's no perfect term, and reducing the harm from the language we use is better than not trying to do that at all. And I agree with all the comments that have been made. Having said all that, I've retired 12 years ago, but I've had a lot of patients over the years who embrace the term addict for them to describe themselves, and in our conversations, they would refer to themselves as addicts, and I would say to them that I'm uncomfortable with that, but I'll use it in our discussions, but nowhere else. So that goes back to Mark's second point about that we have to accept the language that the people we're trying to help accept. I think that's important. But I notice in other contexts that a lot of same-sex attracted people are now like the term queer, and a lot of African Americans in the United States embrace the term Black, which for many decades was deeply disliked. So we, I think, have to keep an open mind about it. It's an important issue, but there are many more important issues, including changing legislation. That's the critical one. And we can see when we look at what's happened with gay liberation around the world, that it was changing the legislation did more to reduce discrimination than anything else. And that's, after all, a key objective, is to reduce discrimination.
Thank you for the lovely point, Dr. Wodak. I have very thoroughly enjoyed our talk and our conversation tonight.
Is Dr. Mary Ashino, joins us from Ghana. So it's really a pleasure to introduce her. She is a physician specialist in public health with emphasis on health policy and assisted management. Dr. Ashino has experience implementing several national and international maternal and child health flagship projects and programs. She serves on Ghana's National Quality Steering Committee and Ghana's Public Health Association, and she serves on Ghana's National Quality Steering Committee and Ghana's Public Health Association, and is a West Africa Hub Representative for Harvard University's Planetary Health Alliance. Dr. Ashino has been a member of the West African Drug Policy Network since 2015 and has provided public health policy analysis and advocacy towards drug decriminalization for the annual Support Don't Punish campaigns. Thank you very much for being here, Dr. Ashino.
Thank you so much, Bryon. And let me start by saying thank you for the invitation and the opportunity to have this very important conversation with our colleagues. I want to start off from where I got into drug policy reforms, and then reflect on Bryon's very insightful presentation by giving 6 thoughts on how we can get doctors more involved in drug policy reforms. So let me say that Bryon has introduced me. I have been in government most of my professional practice. I've been with the Ghana Health Service Ministry of Health for the last 15 years. In 2014, I got the opportunity to go on the Mandela Washington Fellowship Program. And when I got back, I was introduced to the West African Drug Policy Network to support advocacy. And as just like a typical doctor, I was totally confused. I didn't know what was happening. I think a few months down the line, I took a course on drug policy reforms. I educated myself. We all know that doctors studied pharmacology back in school, but being an advocate for drug policy reforms is also a very different area. So I had the opportunity to join the Support Don't Punish campaign each of the years, and then also supported the decriminalization campaign of the West African Drug Policy Network. So Bryon has conceptualized very beautifully the problem with doctors. From my experience, I would describe it as what I feel has been a very lonely journey, being an advocate as a medical doctor in the field of drug policy reforms. And I have 6 points that I feel can help us to advance this course. So the first one is that we are scientists, so we have to continue using the science, because it's really the language that doctors really understand. Bryon had shown some data which I find very useful. We need to continuously share the data with doctors, because the truth is, depending on the curriculum that doctors are trained with in different countries, there might not be emphasis so much on the epidemiology of drug use. And doctors might not always be aware about the health problems associated with drug use or bad drug policies. And they might underestimate the importance of pushing for policy changes when it comes to appropriate drug use. So that is the first one, to make sure that we keep presenting the data to doctors. They need to know the burden of the problem, and in terms of epidemiology, but also in terms of policy and what bad policies can do to our patients. Then the second one is that we need to build capacity on advocacy and campaigning. And this also includes our knowledge as doctors on human rights perspectives and on the legal perspectives as well. Because there's that tendency as doctors to be clinic bound, right? And it's even very difficult to get doctors from the clinical medicine to public health. So we really need to make sure that we are capacitating doctors with the non-traditional skills that were not part of our training, like campaigning skills and advocacy skills. Very important. The third one is that we need to encourage research by doctors on drugs use. So this could range from very basic analysis of clinical data, the patients they are seeing in clinic. What is the data telling them? We go to clinic all the time. We have the tendency to run from consulting room to the theater to ward rounds, but we are not even stopping to look at our data. But it would amaze us how the data can speak to doctors and convince them how they need to be part of the process to push for appropriate policy reforms for drug use. The fourth one is that doctors play a very critical role in reducing stigma. And this is not, when we talk about stigma, we are quick to blame others, right? We think that the stigma is coming from people who have not been educated. But what I have seen in other areas where there was stigma was a problem, like HIV, like TB, like COVID, there was actually more stigma among doctors. So we need to make sure that we are pushing doctors to reduce stigma first among doctors, and then also be champions to reduce stigma in non-physicians. And I realized that sometimes, even as trained doctors, we have the tendency to mix science with moral standards. So we are even likely to judge patients sitting by us, in front of us when they need care. And we are quick to stigmatize patients. This is real, no matter how much education we have had. So there's need for constant sensitization and self-awareness about doctors ourselves being tools of stigmatization, and the role we can play in reducing that stigma among ourselves and also among non-physicians. The fifth one is that we have good entry points for integrating drug policy reform interventions into programs that doctors are already comfortable with implementing. So I realized that our colleagues in National AIDS control programs, for example, are very comfortable with harm reduction activities. So those are activities that become the beginning of the conversation to get doctors interested in drug policy reforms and to make sure that patients become safer, and also give doctors job satisfaction, because we get excited when our patients are safer. The final one is that Bryon showed us a data that shows that doctors, nurses, pharmacists, they are trusted by the community. What I have also seen is that doctors are also trusted by doctors. So if we have physician champions, doctors are more likely to listen to them compared to if you had non-physician champions. Sometimes when we want advocates, we are likely to go in for celebrities and we say they have a voice. But really, most of the time, doctors are more likely to listen to each other. I'd like to close by sharing this joke with you. I remember one time we have a lady doctors page. So I was doing a little bit of advocacy about decriminalization of drug use. And the debate got very heated, right? Because we had doctors there who are pastors and who are very religious people, and they already have the moral stereotype that anything drug use, they don't even want to hear about it in the first place. And then just halfway into the conversation, I got a private message and somebody was asking me, Doc, are you sure you don't use drugs? You know, just because I was promoting what doctors have to do to support drug policy reforms. So that is just how prejudiced we can be as doctors. We are still human. And so all the things that we need to do to make sure that doctors have the right mindset, they have the right orientation to promote drug policies, I think we need to do a lot of that. And Doctors for Drug Policy Reforms is one of those very, very important groups. And Bryon, I would like to end here and give you many thanks for the opportunity to share my experiences. Thank you.
Thank you very much, Mary. Really appreciate these words of wisdom, and hope to hear more during the Q&A from your thoughts on this. Our next speaker is Dr. Emmanuel Luyirika from Uganda. Dr. Luyirika is an executive director of the American Palliative Care Association and a board member of the Worldwide Hospice Palliative Care Alliance. He has served on several technical committees at the Ministry of Health, Uganda, Uganda AIDS Commission, WHO, UNICEF, and UNAIDS, and is vice chairperson of the Council of Institute of Hospice and Palliative Care in Africa. Dr. Luyirika has published on HIV care and treatment and palliative care in Africa. He has a special interest in the interplay between palliative care and disease prevention efforts for communicable and non-communicable diseases at the household level, as well as the integration of palliative care into existing health systems for sustainability. He will be speaking on improving access to controlled medicines and palliative care. Thank you for being here.
Thank you very much for the kind introduction, and thank you very much, colleagues, for joining this webinar. As has been shared, I enter this discussion from the point of view of palliative care, where I'm involved, and it's my privilege to, first of all, give you some information about the African Palliative Care Association. So we work towards 4 main objectives. The first one is to increase awareness about palliative and comprehensive chronic care linked to advocacy through collaboration with all stakeholders. In that, we run several activities as I've listed them there. And then the second one is to support the improvement of health systems in Africa through the integration of palliative and comprehensive chronic care at all levels. And one key aspect there is access to essential controlled medicines, and as well as technologies, training and education, policy development, and then palliative care service delivery. And the third one is to build an evidence base for palliative and comprehensive chronic care in Africa. And the last objective really is sustainability for us as an organization, but also the approach. The picture you see here is a picture we took at our last conference with the ministers of health from Africa. Usually before we host the conference, the first day is a session for ministers of health, so that they are aware about the issues that we deal with. So we have barriers to accessing controlled medicines in Africa for a number of reasons. The first one is stringent and punitive laws whose focus is more on control against illicit use than access for medical and scientific use. This is a huge barrier that even countries that are doing well in terms of access, you still have them reaching only about 15% of the people who need these medicines. The governments are also offering limited financing, making it difficult for patients to access these medicines. You also have inadequately prepared and informed and trained health workers. My colleague has already talked about that. In fact, many health workers would rather stay away from these medicines than getting involved. The other barrier is lack of awareness among policymakers, health workers, even patients themselves or people who need to use these medicines, the regulatory authorities, and in many countries in Africa, we have narcotics police who are just there to enforce non-access. We also have issues among trainers of healthcare workers and, of course, the general public. So why is access to essential medicines, to essential controlled medicines important? It's because they are on the WHO essential medicines list, and they are needed for mental and neurological disorders, for management of substance use disorders, for palliative care. It's in red just because that's my main area of engagement. They are used in anesthesia in general, and also especially in surgery obstetrics, but also in other situations. In the context of palliative care, we use these medicines for pain management for both adults and children. We use them to manage breathlessness, nausea, vomiting, diarrhea, patients who have severe decubitus ulcers, which result in unbearable suffering, even some of the symptoms like hiccup. Then we have anxiety, depression, seizures, and other psychiatric issues in palliative care, and many other conditions within the palliative care context. And so, because of this lack of access, Uganda, through its pioneer, Professor Anne Merriman, came to Uganda in 1993 and found that many patients were suffering without access to these controlled medicines. And so she started local morphine reconstitution using powder and producing the liquid, which then would be given to patients. And that worked very well. And then in 1998, Dame Ruth Sims and Dr. Veronica Moss from Mildmay, UK, started Mildmay International Uganda, which is an HIV facility. And they also started reconstitution for patients whom they were treating. And in 2010, the Uganda government, through the Ministry of Health, agreed to aggregate all the reconstitution into one unit, and started reconstitution and then giving this medicine free of charge to all patients who needed it. And in this picture, you have Professor Anne Merriman, who turned 89 last month. She's still active in Uganda, though older than she used to be. And then we have Dr. Stephen Watiti himself, somebody who has benefited from palliative care and is an advocate. These two met, they were having a discussion at one of our conferences, which was in Kampala in 2022. So Professor Anne Merriman was an innovator of something that could be used to ensure increased access. And this Ugandan mode of low-cost oral liquid morphine production, it's a whole system of strategic partnership from Ministry of Health, which provides the money to buy the morphine powder, and then it's procured through the joint medical stores, which is owned by the faith-based facilities, and then the production is done at Hospice Africa, which is a charitable entity. And after production, The produced medicines are warehoused at the national medical stores, which is the government-owned facility. And then distribution is done by both the joint medical stores, which provides to charitable hospitals and hospices, and then the national medical stores to government hospitals. And then training of prescribers, including nurses, clinical officers, because now in Uganda you have nurses who are allowed to prescribe opioids once they are appropriately trained. And so the training is done by Hospice Africa Uganda. And then at the African Palliative Care Association, we offer scholarships for people to be trained. Ministry of Health also accredits the training and supports the training. And then the Palliative Care Association of Uganda, PICAO, is responsible for accrediting sites where these medicines are placed and then prescribed. The dispensing at health facilities happens, but also in patients' homes. So patients are free to have enough supply, maybe for a month, and after that they can come for more, or when the home visitors go, then they take more of the medicines. So medicines can be administered at home without the restriction of being restricted to the hospital setting. There is also a national committee of all stakeholders that meets every 3 months to monitor the progress of this implementation program. So how is it done? It's done, there is food color that is used to show the strength. So red, we have red and green, and then a preservative, sodium benzoate, and then the morphine sulfate powder, and then purified water. This picture is the offices of the new new offices of the national medical stores with the minister and the president and other stakeholders, which were opened about 2 years ago, and that is how it looks inside. This is the red color for the strength of 10 milligrams per ml, and then green is for 1 milligram per ml in the solution, and then that's the powder, which is the active ingredient. And that is the water purification plant. And then here the whole process is seen there. You have the bottling plant indicated there, of course using those colored bottles, amber bottles, so that the effect of direct light is reduced. And these are the formulations, as I said. So a patient takes enough as prescribed by the doctor, basing on the strength, and then they are able to take it from home using a syringe. They can know how many meals they are supposed to take based on the prescription, and then before they go to bed, it is doubled. So those are the bottles, and then these are the colors, how the different strengths look like. Red, as I said, 10 milligrams per ml of the solution, and then green is 1 milligram per ml of solution. And this is just the supply chain as it moves. You have from the production that you saw, packaged, then delivered at the national medical stores, then the national medical stores delivers using these trucks to the various health units where the medicine is required. Why oral liquid morphine? It's easier to titrate doses. It's not a target of illicit use by anybody. You cannot convert that liquid into anything else. It's easier to manufacture. It's easier and it's cheaper. And because it's not targeted, so safety, once it's made a solution, then you don't have to worry about the securing as you would worry about the powder itself. So patients can freely take their medicines as required. And then when you create awareness about this whole process, you don't forget the policymakers. As I said, they are often not informed. And in this picture, you see, we had, in this picture, we had members of parliament of the East African Legislative Assembly here, and then here the local organization and some of our staff with the Committee of Parliament in Uganda. So policymakers are very important to engage and make them aware that this is something that needs to be done. Countries where we've provided this kind of technical assistance are listed here. We have Kenya, Rwanda, Eswatini, and other countries. As a way forward, we need policies and investments to be made to improve access to these medicines, expand the prescriber base, and also train health workers and other stakeholders. Never forget the police, because for them, they come from a control position. They will even arrest patients carrying their medicines if they are not aware. So this picture we took with police officers from the Uganda police, where we had created awareness so that they make their teams aware. Let patients go home with their medicines, or if you find a nurse who, because in some countries it's only the doctors who are allowed to have or prescribe these medicines, but in our case, the nurses are also allowed, specific nurses, so then they are aware and they don't make mistakes. Thank you very much, and I've put in a reference there where you can access our tool that can be modified by other countries, and I acknowledge all those that support access to medicines and palliative care in general. Thank you very much.
Thank you. That was really interesting and really emphasized to me the difference between the issues facing us in different parts of the world. This is the opposite kind of problem that we've had in the US. So thank you. So now we have some good time for Q&A. So let me start out. I've got a ton of questions, but let me start out with a question in the chat from Crystal Carrington, the first part. And Crystal is on the board of D4DPR, a wonderful board member. This is to Doctors Shinyo and Luyurika. If you'll notice, Luyurika is coming off my tongue a little bit easier now that I've said it a few times. What have you found to be the most effective in shifting the attitudes of doctors who have strong moral and or religious objections to drug reform? I'm concerned that the entrenched prejudices may lead some doctors to dismiss data by selectively seeking information that confirms their biases.
Maybe let me start, and then my colleague will look at it from her angle as well. For us, I think one of the best, many people believe the things they believe and do the things they believe because they have been told something somewhere. And so it is important for you to give them information and see the important, and so that they can see things from the other angle. Why we are very interested in getting involved in the drug reforms is because the channel that delivers the medicines for harm reduction is the same channel that delivers medicine for palliative care and others. They say the controlled medicines. And the barriers that you face for access to medicines to manage substance use disorders are the same obstacles you face when you want to access medicines for palliative care. I think HIV taught us something. My colleague talked about the condom, and we had issues around the condom, especially among the religious people, but also among doctors who felt strongly that patients should not be involved, especially people who held strong religious views that they shouldn't be involved. But with awareness and equipping them with the information and the benefits that come out of that, it became very important. For us at our organization, we've just had a session on, we've just had webinars on palliative psychiatry. And one of the key things that we wrongly assume that doctors know certain things when actually they don't know. It's therefore important for us to design packages that target doctors and nurses as far as drug reform is concerned. And not only that, but also sit down with the people who design the policies for the doctors. We found that many of the people, from my vantage point, many of the people who are in rehab centers in our country, they are children of very prominent people. They are children of very rich people. And this is not something they expected. And then you identify champions even among the parents of those children to help you push that agenda. We got a setback in Uganda that the drug law they have just passed is actually very stringent. Even after meeting Parliament, they still made that law very stringent, especially on patients who need controlled medicines for substance use disorders and people who are found with controlled substances. It is still very stringent. But even within that environment, if you involve the police and the health workers and they know why they should be on the side of the person who has the challenge, I think that is very important. We are not yet there, but for us, we are using palliative care to create awareness even for the other aspects where we need to use the controlled substances. I think I'll stop there and hand over to my colleague.
Okay, thank you very much, Emmanuel. So, Crystal, that's a very good question. And from my experience, I have used 3 approaches. The first approach, when I meet a physician who is a public health person, I start from primary health care, and then I talk about universal health coverage. And then I say that, you know, we are promoting health for all and leaving no one behind. And then that is the language that they understand. And then I'm able to get them to appreciate the public health lens when it comes to drug use. Because I think one of the challenges too has been that historically, drug use has been a security issue, right? In most countries, especially in Africa, the interventions are nested within the security system and not the health system. So psychologically, that makes it very far. Doctors perceive it as something that is very far from them, and it's none of their business, apart from just being in clinic and giving care to patients. So when you use the public health angle with physicians who are public health specialists, you are able to capture their attention. When you meet doctors who are clinicians, then I use the patient safety angle, because I always say that whether you are public health or clinician, once you are a trained doctor, actually the principle is to do no harm. And harm doesn't always come from action. It also comes from inaction. So the fact that your patients are not having access to the medicines that they need, it's something that does not promote patient safety. So if you meet a clinician and you put patient safety and do no harm and making sure that patients go home with a higher quality of care, they should feel much better than when they came to hospital. Then the clinician really understands that language, because that is really the priority of every clinician, to make sure that their patient goes home feeling much, much better. But the third thing that I have found to be very useful is that whether you are a clinician or a public health specialist, you are human. So that is the third language, the human language, and saying that, look, what we need is compassion. And those of us who feel we are not part of people who are using drugs and might, not be in our position, we have a privileged position. And it's not because of what we do, it's just somehow we have that position. And we have the power and the knowledge as doctors to then help people who are not in that position. So that is a very reflective approach. And I remember one of the doctors that was challenging, arguing with me. And I said, are you telling me now that if I found, God forbid, but if I found your son or your cousin using a small amount of drugs, that person should now be labeled as a criminal and put in jail, and then their schooling and everything, all their future dreams doesn't come true? at a very personal level. Do you really think that's what should happen? And she said, God forbid, that would never happen. I say, yes, so sometimes just being reflexive and putting empathy, compassion, and putting ourselves in the shoes of others. I think that conversation really touches people. And then they wake up from the moral perspective, and they are able to appreciate more what you're trying to tell them. So I think those three approaches have helped in my conversation with doctors. And I hope that it helps you as well. Yeah, thank you.
Thank you. Those were both excellent responses, and I really appreciate that input. Thank you. I wanted to follow up, Emmanuel, with the difficulty with getting these drugs, because this is medications, and again, this is a much different problems than we face in the U.S. So I'm assuming primarily you were talking about opioids, but you referred to other medications like for mental health disorders and substance use disorders. I'm assuming you're referring to methadone and maybe Suboxone and maybe some others. Could you clarify?
Yes, the issue is the issue of access is a serious one. In the case of palliative care, the centers that can handle those medicines are accredited. In terms of centers where they manage substance use disorders, like our National Mental Health Hospital has a unit within it, and then we have private units that have been set up, but they must have a physician who supervises those units, and those are for pay. They are not free access. Even the unit within the National Mental Referral Hospital, it is paid for. A patient pays about $20 a day to be in that unit if they need to be treated, and staying for almost 90 days. Very few people can afford that kind of arrangement. So apart from the cost, the medicines themselves are not easily available within the system, and so the patient have a double jeopardy. You don't have money, so you can't go into a private unit. You don't have money, you can't go into a government unit. Even if you have money, you may live in a place where you cannot access these medicines because there is no appropriate unit to give you those medicines. So there are a number of factors in terms of access. When you go to opioids themselves, it's a major issue because there are people who are designated as prescribers. The advantage we have now that in the Ugandan context, they have somehow allowed non-doctors to prescribe these controlled medicines, especially appropriately trained nurses, clinical officers or medical assistants, and midwives. So that somehow helps a bit, but it doesn't help with the bigger issue of patients or persons with substance use disorders, because those services are not easily accessed and the medicines are not available at the lower level where you might be living several kilometers away from the city center. I hope that clears that.
Yeah, thank you. We have a question from Alex Wood, one of our speakers from last night in Australia. So it must be some god-awful time in Australia right now. He notes Dr. Shino hit on a it's a different. Oh, that was Alex Wodak. This is Alex Wood, of course. He's a young doctor from the US. Dr. Ashino hit on a palpable barrier I've noticed among my resident peers: advocacy for people who use drugs invites being labeled or outed as users of substances themselves. What is the panel's thoughts on how to tackle this dynamic? I think it kind of came up earlier a little bit with people will ask you, oh, you must use substances yourself.
Okay.
Oh, Mary, go ahead.
do you want me to say so? Okay, so I think personally it's a leadership challenge, right? And when you're a leader and you add your voice to something, or you decide to stand for something, you will certainly get a few names. And I think it's, for me, it doesn't really bother me if somebody thinks I'm using drugs. I mean, if it's working for me and I have a good life, I don't have a problem with that. So I think it's not, as a leader, you should know that going into an area that most people stigmatize, you need a very good psychological strength and, you know, being clear in your mind that sometimes there's a price to pay, and that's getting a name. And so when you're given a name, you don't really, it's not something that really matters. You just laugh over it and that's it. So personally, it's not really been a problem to me for people to say, oh, are you using drugs? Sometimes I just say yes and I move, because I don't even want to invest in having that conversation. So I think it's not really a problem. It's a leadership thing, and that's how I handle it. Yeah, but maybe my colleagues would have something to add about their experience. I don't know the names they have incurred in the process. So yeah, thank you.
But it's interesting, you could push back that most of my colleagues do use drugs, and that's alcohol. So about 80% of physicians drink. So there's a lot of drugs. We just arbitrarily make some drugs illegal and stigmatize them, and some drugs aren't. But I do think that it's fascinating that the physician drug use is an issue, and that a lot of people who advocate probably are so ashamed and stigmatized and isolated that they'd be the last people to be trying to speak out for drug use. So it's just an excuse for people not to be involved. But the stigma of even prescribing, and one of the underlying reasons why North America has such a catastrophic number of deaths is prescribers who have stopped prescribing. So these drugs that have been very useful for people, doctors have been given the message that everybody's watching them and that they are the cause of this epidemic of opioids, and they've stopped prescribing. And there's so many people that have been using opioids for a long time, all of a sudden are cut off and have no alternatives but to look for illegal sources of drugs, and they turn out to be unsafe and they die. So physicians in some regards are responsible for some of the deaths by putting on their moralistic and I think cowardly caps and cutting people off from drugs that they were using and need. And this has been a huge problem. And part of it is the governance of the physicians who are really watching and clamping down. And I know many of my colleagues have got reprimanded by the college for prescribing too many opioids. It's, in my case, for the last 2 years of practice, that's the only drugs that I ever prescribed were opioids, because it was part of these research projects. So I've been waiting for this letter in my mailbox for reprimand, but they've left me alone so far. But if they were looking for people with deviant prescribing habits, I was the poster child for that in Canada for sure. And so far I'm okay.
Hope that holds up. And I would kind of second what Mark says. I have actually, as I said, I can be more outspoken now. And at I chaired a symposium at CPDD, a major national or international drug research conference on this topic. And I made the comment that when we talked about the importance of lived experience now in our field, at least in the research area, we're typically talking about people who have a substance use disorder and maybe are in recovery and now being able to speak about it. But I said most of us here have lived experience. And, I could acknowledge my use of cannabis and psychedelics, But I said most of us drink, and the vast majority of us use caffeine, which is a psychoactive substance. I mean, that's why we use caffeine. So these are arbitrary distinctions between drugs that we have put on, but we need to acknowledge that we're all substance users, almost all of us. Everybody I know is using something. Any questions? Mark, I had a question about the heroin and hydromorphone safe supply that you used. First, I was wondering, which do you prefer, if either or both are good in different ways? And what I struggle with is, suppose somebody just wants a safe supply. They want to use hydromorphone. They haven't had a past experience with it, but they don't want to risk getting fentanyl. Do we supply them with a dose or two of Dilaudid? You're on mute.
Yeah, I'll save the second part of your question, but the first part is that the Naomi trial that this clinic is based on used methadone versus heroin, and found that people on heroin did much better than the methadone group. And then there was a second trial called Salome, and that used hydromorphone and heroin, and blinded the subjects to those, and there was no difference. So hydromorphone had much less stigma compared to heroin, so many people were switched over to hydromorphone. As new people joined the clinic, they preferred heroin overwhelmingly. So more people now are back on getting heroin. So you could say that blinded, the study at least showed people couldn't really tell the difference, but on the street, people prefer heroin. Unfortunately, now people prefer fentanyl. So at first it was people not really knowing they were getting fentanyl and thought they were getting heroin. But now people, after 8 years, know they're buying fentanyl and prefer the feeling they get with that. It's more potent. It's got a shorter half-life, so people who are, regular users need to inject like 5-6 times a day versus heroin 2 or 3 times a day. So it's much more intensive, and as far as their injection behavior goes, or their sniffing behavior goes. As far as if people want to try an opioid, we don't want them buying on the street. So from a very practical way, yeah, I think I'd way rather, if you're interested in people's safety and well-being, you'd rather give them a quality assured substance to use rather than buying somebody, who's in a dark alley with a hoodie on, So I think practically speaking, that would be the case. One interesting observation from the early Insight days was that people were scared that, well, if you open a supervised injection site, all these people who haven't used drugs before will think it's okay and start coming in and using for the first time. And there was nobody that used for the first time at Insight. So it just was not an invitation to come and use drugs. So everybody brought their own drugs and were regular users. So I think you won't find that many people who come to their physician and say, I'd really like to experiment with these opioids. Can you give me a prescription? But practically speaking, I think that would be a reasonable thing if the alternative was to go buy fentanyl on the street.
Thank you. And we're almost out of time. One last question I wanted to ask for Dr. Ashino. This came from Crystal earlier. What do you think about investing? Is this feasible to invest in public education campaign that would focus on humanizing drug use and its impact?
Yeah, I think it's absolutely feasible, and that should really be one of the groundbreaking interventions. I realize that usually if you want to get doctors interested in areas that they are not, you need a specific programs for only doctors. I think it's managing the power between doctors and non-doctors. Doctors like to be alone, you know. So, for example, I give an example. There's the WHO Quality Rights Program, which was implemented across many African countries. And that is a rights-based training. So it's training doctors and nurses about human rights in delivering high quality services to patients, right? So we can have, and that training was both in person, but there's an also online version, which is self-paced, and doctors can log on and learn. So we can have a similar intervention that is designed with a humanized approach, driven by compassion, patient safety, health for all, do no harm, all the languages and the keywords that doctors were trained with. And that should be something that it should be a good program that most donors will be willing to fund, and which can also be piloted and then scaled up across a lot of countries. I think that would be a very good intervention if we get donors who are interested in this area. And it would open the eye of most doctors, and it should include a legal lens, and because that's an aspect that we are very blind to as doctors, right? Our training doesn't include law, although we do medical ethics. It's not really a legal training. So we need to really think about the curriculum, what should be the content of the program, and what should be the methodology of training. I think it should be a combination of in-person, but also hybrid. Because when you look at low LMICs, you can have one district hospital with just one doctor. So sometimes even taking doctors out of clinic on workshops to train them is difficult. They are not even interested because they say, I can't leave my patients in clinic and come for training. But this is the same training you need to actually give the best of care to your patients. So I think we need to look at the context and also the methodology that would be most suitable for doctors. And it would be one of the very important things that our network can carry forward going forward. So Bryon, this is a recommendation for the executives. Thank you.
Thank you. That is an excellent recommendation. And I did want to say that we have been funded, D4DPR has been funded by Drug Policy Alliance to put together a toolbox that is essentially what you were describing. So I hope I can pick your brain on what you have pulled together here. Anyways, it's time for us to close. Thank you all so much. Dr. Tyndall, Dr. Luyurika, and Ashinyo. This has been excellent. I've learned a lot, and I appreciate everyone's participation, including our participants and our staff. You all have a good day or evening.
Thank you.
Thank you.
Thank you so much. Bye-bye.
Thank you all.